Macrocytic anemia is defined as the mean corpuscular volume of more than 100. And there are two different forms of macrocytic anemia. These are megaloblastic macrocytic anemia or normoblastic macrocytic anemia. So erythroblasts are precursors to the formation of erythrocytes. And erythroblast can be in two different forms. It could be in a megaloblast, which means that they have increased in size, or it could be a normoblast, which means that it has a normal size. So generally, deficiency of vitamin B12 or B9 will interfere with the DNA synthesis, as a consequence of which these cells will be arrested in the G2 stage of the cell development, and thus they would continue to grow without mitosis. And thus these erythroblasts will increase in size and form megaloblasts, and once they're released into the circulation, they would have increased size and be macrocytic. On the other hand, conditions like alcoholism, hypothyroidism, or liver disease, the size of erythroblasts is normal, so there would be normoblasts that are released into the circulation as erythrocytes, and then later on, once they are released as normal red blood cells, then there are some changes that will make them macrocytic. So the initial production of erythroblasts is normal, but then later on red blood cells will increase in size. So while the exact mechanism of macrocytic anemia in these conditions is not known, it's thought that alcoholism, by increasing the acetaldehyde, which is a metabolite of the alcohol, it will affect the membrane of the red blood cells and cause macrocytosis. Hypothyroidism, its mechanism is not known, and with liver disease, it's thought that due to the increased lipid deposition in the red blood cell membranes, it will again cause macrocytic. Now next, I would like to explain vitamin B12 and vitamin B9 in more details. So vitamin B12 is required for two important reactions, and these include the conversion of the homocysteine into methionine, and it's also required for the conversion of methylmalonyl coenzyme A into succinyl coenzyme A. So if there is deficiency of vitamin B12, homocysteine and methylmalonyl coenzyme A will increase in these patients, and that is one diagnostic tool to detect vitamin B12 deficiency. With vitamin B9 deficiency, on the other hand, only homocysteine levels will increase, but the methylmalonyl acid levels would be normal. Now, the stores of B12 and B9 can last for some time. With B12, it lasts about 3 years, while with B9, it can quickly get depleted, and as much as 3 months deficiency in the supply of vitamin B9 can cause folate deficiency. So common causes of vitamin B12 deficiency include pernicious anemia. So what happens is that intrinsic factor produced by the gastric parietal cells will bind to the vitamin B12 and enhance its absorption in the ileum. So once there is pernicious anemia due to the deficiency of the intrinsic factors, these patients cannot absorb vitamin B12. Alternatively, if these patients have gastrectomy, then there are no parietal cells to produce intrinsic factor, and again there would be vitamin B12 deficiency. Alternatively, if there is an ileal disease or ileal resection, or for instance Crohn's disease, then there would be interference with the absorption of the vitamin B12 in the ileum. As I mentioned, intrinsic factor, once it binds to the B12, it has to be absorbed in the ileum, and thus since there is ileal disease, these patients will have vitamin B12 deficiency. Alternatively, poor diet could cause vitamin B12 deficiency. So vitamin B12 is mainly found in meat, and thus vegetarians are at increased risk of vitamin B12 deficiency. And finally, infection by Diphthylobothrium latum, the infectious agents which will compete for vitamin B12 with the host, as a consequence of which there would be B12 deficiency. And then for B9, as I mentioned, its stores can get depleted really quickly. It could be from poor diet, alcoholism, administration of folate antagonists such as methotrexate, or administration of the seizure medications like phenytoin or carbamazepine can cause vitamin B9 deficiency. Now, the clinical manifestations of vitamin B9 and B12 is kind of similar, except that B9 does not show any neurological manifestations. So both B12 and B9 will cause the megaloblastic macrocytic anemia. They present with the hypercytokemia segmented neutrophils, it causes glossitis. And then so these three conditions are seen with B9, and then one other difference is that B12 also causes neuropathy. So just note that B9 deficiency does not cause neuropathy, only B12 causes that. And this is due to the demyelination of the dorsal column, which is required for position and vibration sense, and also due to the demyelination of the lateral corticospinal and the spinothalamic tract. So here is an example of the hypersegmented PMN, which has multiple lobes. And then in addition, due to the demyelination, these patients present with upper motor neuron symptoms such as increased deep tendon reflexes and spasticity, and also due to the demyelination of the dorsal column, they present with the loss of position and vibration sensation. Now, to understand the etiology of vitamin B12 deficiency, you can use the Schilling test, and how it works is that in step 1, you will provide the patient with a radio-labeled B12, and if B12 is detected in the urine, then it means that it has been absorbed, and thus the reason for vitamin B12 deficiency is simply the poor dietary intake. However, if you do not detect B12 in the urine, then the deficiency could be either due to the lack of the intrinsic factor, or it could be problem with the absorption of the B12 in the ileum, and thus you will have to use step 2 to find out the underlying cause of it. So next you will provide radio-labeled B12 in addition to intrinsic factor. Now if there is again detection of vitamin B12 in the urine, it means that the intrinsic factor was deficient, and once you supplied that, patient was able to absorb vitamin B12. But then if B12 with intrinsic factor is still not absorbed, then it means that the problem is with the ileum. So no matter whether B12 or B12 with intrinsic factor is provided, since the ileum cannot absorb it, these patients will always have vitamin B12 deficiency, and you will have to then provide with the injection of B12 because it cannot be absorbed from the GI tract. And that concludes our discussion.